This is Citrusdal. I took these photos a few years ago on a family trip. It's a small town about 2 hours from Cape Town, and as its name suggests, the area is famous for citrus farming. Now imagine this. You're a community service doctor at Citrusdal Hospital. It's Friday, late afternoon. A farmer comes in after falling from a ladder. He has numbness in his fingers and a swollen wrist. You're worried about a nerve injury or more complicated fracture. There's no orthopedic surgeon on call. It's just you and your colleagues covering the call. Before Vula, you'd phone around and try and get hold of someone at Paarl Hospital, or maybe even Tygerberg Hospital. Maybe you send the patient on an urgent transfer, even if it wasn't necessary. With Vula, you take a photo of the x-ray, send it through to the on-call orthopedic surgeon, and write a quick summary. Within minutes, you get feedback on what to do now, whether the patient needs to travel tonight, or if it's safe for them to come for a follow-up on Monday. This makes a huge difference. It keeps the local hospital from sending patients unnecessarily and gives doctors peace of mind that they're doing the right thing. Vula connects healthcare providers so patients get the right care at the right time in the right place. So what is Vula? Vula is an app that helps connect primary healthcare workers directly to specialists for advice and referrals. Instead of phoning around or relying on faxes and landlines, they can send a structured referral or ask a question through the app, often sharing images and other details to help explain the case more clearly. It's used by a wide range of healthcare professionals and specialist teams across different regions, disciplines, and this makes it easier to get timely input when needed. Beyond just helping move patients to the right place, Vula also supports daily learning. Every time a clinician gets feedback from a specialist, it helps build their skill and confidence over time. Today, there are over 40,000 healthcare professionals using Vula, helping over 2,000 patients per day. The average response time from a specialist is about 15 minutes, and in rural areas, 1 in 5 patients can be helped with that guidance without needing to travel to a bigger hospital. A real example of how Vula changes things comes from Ngwelazana Hospital. It's a busy orthopedic and trauma center in northern KZN. It serves over 2 million people, and before Vula, many patients had to travel long distances, sometimes about 250 kilometers, only to find out they didn't really need specialist care. With Vula, now 600 referrals are vetted upfront through the app. Patients who do travel have been vetted already. This saves them long trips, keeps the local clinic from sending patients unnecessarily, and reduces orthopedic center numbers. Routine follow-ups have also become easier. Instead of asking patients to return to the tertiary hospital, the local district hospital doctor can take an x-ray or ask questions through the app. Having direct guidance from specialists also means that local doctors become more comfortable with each case. Local teams can handle more cases on their own, and patients benefit from care that's closer to home. This is a good example of how a digital tool isn't just about saving time. It can quietly change referral patterns so it strengthens care at a district level. The Ngwelazana Hospital story shows us what's possible when different levels within the public sector work together. But collaboration doesn't have to stop there. The next example looks at what's possible when public and private providers work together, and what this means for the people who often move between the two systems. In eThekwini district, a pilot project set out to see what this kind of cross-sector collaboration could look like in practice. Many people in the area choose to see a private GP first, even if they don't have private medical aid. This was due to shorter waiting times, convenient location, and the perception of better quality care. But if TB is suspected, the cost of treating privately often becomes a barrier, and care often ends up shifting into the public sector. The pilot made that transition smoother. Private GPs could collect sputum samples right in their labs and send them to public labs for gen expert testing, free of charge to the patient. Vula tied it all together. GPs could track results, get advice from TB specialists, and they were reminded to offer HIV testing too. Each part of the system did what it does best. Private GPs reach patients who might never walk into a TB clinic on their own. Public labs provided fast, high-quality testing. And once someone was diagnosed with TB, public clinics took over, for follow-up and treatment. The numbers tell the real story. 1 in 5 patients tested through the pilot had TB. 93% of those started treatment, often within just 2 days. Many then carried on treatment in public clinics, so care didn't stop at the GP's door. HIV testing rates also went up to around 88%, matching what's seen in the public sector. Treatment completion was strong, and fewer patients died compared to national averages. This shows what happens when private and public sectors don't work in parallel, but talk to each other. Diagnosis happens quicker, treatment starts sooner, and patients aren't left to navigate the gap alone. It's a practical example of collaboration that directly improves outcomes, and it matters most for people who often sit between the two systems. And that brings us to the practical question. Who are the patients who start care in the private sector and then move into the public sector? This group is often called the missing middle. The missing middle isn't just an abstract term. It's a group we see clearly when we look at how people utilize healthcare. The General Household Survey data found that 26.2% of households say they would first use a private GP or hospital when someone becomes ill or has an accident. Yet only 15.6% of people are covered by medical aid. This points to a real behavior. Many households, even without medical scheme coverage, still choose private primary care for that first point of contact. The LIMS study helps us explain why. It found that people in this income band place a much higher value on out-of-hospital cover than in-hospital cover. The value that they placed on out-of-hospital benefits was about 50% higher than hospital cover. Around 22% of outpatient visits by patients without medical scheme coverage were to private GPs. When asked why they chose private GPs, the reasons were simple. People spoke about shorter waiting times, more convenient location, and the perception of better quality care. Many people, even without formal cover, made the choice to use private primary care because it felt faster. But when the costs increase, for example, if specialists or hospital care is needed, patients often move into the public sector. Their treatment pathway rarely sits within one system. Instead, it starts at the private GP and then moves into the public system when more complex or expensive treatment is needed. This is exactly where collaboration between the two sectors matters the most. Without coordination, patients can face delays, duplication, or gaps in care. But with tools that connect healthcare providers across sectors, these transitions can be smoother and quicker, and patients can begin to experience care as part of a single journey rather than two separate systems. And that brings us to the practical question. What does the treatment pathway actually look like for these patients? For most patients who start in the public sector, they wait to be seen at a clinic, and if they need specialist care, they get a referral letter from the clinic. They then take this printed referral to the hospital to see the specialist team. But because the clinics are often busy, this can take a lot of time. For patients who instead pay to start their journey privately, the journey is a little different. The private GP gives them a referral letter for the hospital, which means that they avoid waiting in the line before getting referred. But without something like Vula, it's still a paper process, and it can still take a while before the patient is seen. This isn't just theory. My gran, who was recently diagnosed with Parkinson's, started at a private GP and then was referred to the public sector for specialist care. Because the referral didn't go through Vula, she mostly had tests done at her first appointment and only got help months later at her next visit. This showed me that without tools like Vula, even when patients pay to start care privately, coordination can fall through, and patients feel the impact directly. But when Vula is used, either by a private GP or clinic doctor, the referral goes straight to the doctor. And because it's a doctor-to-doctor communication, specialists often reply faster. This means that they can give advice before the appointment or request tests. So when the patient shows up to the specialist team already knows about them. So the whole process can be smoother, faster, and better coordinated. We've talked about how Vula supports connections between private and public care. But to help to see what this looks like, we're going to look at a few examples. One example that stood out to me was a patient who came into a private ER late at night with organophosphate poisoning. Usually, this needs intensive care, but the patient didn't have medical aid. The private doctors worked together on Vula to contact the ICU team at Livingston Hospital. At around 2:15 in the morning, the public sector doctors replied. They gave advice on how to manage the patient while they waited and even asked for a few tests to help them prepare. By 2:41 in the afternoon, a bed became available and the patient could be transferred safely. In total, 4 different doctors worked together on Vula to make this happen. It's a small window into how this isn't just about systems and apps. It's really about patients and about people working together across sectors so that patients don't fall through the cracks. In another example, a patient in private care had cover for an ultrasound, but not the surgery they needed. The private doctor sent the ultrasound through to the Vula to the public sector doctor. He gave the patient a printed referral to copy to carry as a personal record. Because of this clear communication, the patient didn't have to get an ultrasound done again in the public sector. This speeded up the patient's access to surgery. And this smooth coordination involved 2 doctors working together across the private and public sectors to ensure that patients received timely care without unnecessary delays. Another example shows how even a small amount of coordination can make a real difference. A patient developed an abscess that required surgical drainage. The private doctor, unsure about the best approach, used Vula to consult a public sector surgeon. Although there were no beds available in the public hospital, the surgeon guided the private GP to safely perform the procedure in the GP's own procedure room. The private GP carried out the procedure successfully, and the patient recovered well with follow-up treatment. This collaboration between 2 doctors ensured effective treatment despite limited resources. This isn't just happening occasionally, it's happening daily. In KZN, about 9% of referrals through Vula to tertiary public hospitals come from private providers. In the Eastern Cape, it's about 38%, and in the Western Cape, it's around 58%. If we zoom in a bit more, the top 5 hospitals with the highest private referrals all come from the Western Cape. These are Groote Schuur, Tygerberg, Karl Bremer, and Mitchell's Plain. At Groote Schuur, about 62% of referrals come from private providers. Easter River's close behind at 61%, and then Tygerberg at 59%. What this really shows is that collaboration between public and private providers isn't unusual or on the margin. Instead, it's already a part of everyday practice, and at some hospitals, it makes up the most of the referrals coming through. It's also not just about private GPs. Many doctors working in the biggest private hospital groups use Vula every day. At Mediclinic, 56% of doctors in their hospitals are using Vula, with hundreds of doctors and healthcare professionals reaching out to public sector teams. At Life Healthcare, doctors in about 50% of their hospitals are using Vula, and at Netcare, it's about 33%. This includes emergency doctors, surgeons, nurses, psychiatrists, physiotherapists, and many others who might need to arrange for a transfer or get advice. What this suggests is that South Africa doesn't really have two separate healthcare systems. Instead, it's a spectrum. On the one end, there are people with medical aid coverage using the private system. On the other, there are those who rely on the public system. And in the middle, there are many patients who move between the two systems, sometimes paying out of pocket to see a private GP, and sometimes relying on public hospitals for specialists or hospital care. Tools like Vula help make this overlap work better. They turn what could be fragmented and informal into a more traceable and structured process. These examples also show that when public and private healthcare providers work together, the patient benefits. Diagnosis happens faster and treatment starts sooner. In the end, it's not about separate systems. It's about making sure that everyone gets the right care at the right time in the right place. Thank you. I just want to do a little shout out to Vula and specifically Marika and William and Ruth for all of their help with this presentation. And if you have any other questions, William is here, but you can scan the QR code that is up on the screen now. Thank you.